Hello, my name is Alex Contiero, and I'm here today to present some information on a condition known as CHARGE syndrome. CHARGE syndrome is characterized by unusual congenital features seen in a number of newborn children. CHARGE syndrome was first recognized in 1979 by Dr. B. D. Hall, formerly known as CHARGE association or Hall-Hitner syndrome, which indicates a non-random pattern of congenital anomalies that occurs together. In 1981, Dr. Pagan coined the term CHARGE, an acronym summarized the six cardinal clinical features. CHARGE syndrome is an autosomal dominant condition with no known family history. It is a mutation of the CHD7 gene within the chromosome 8. CHD7 is known to be involved in the transcription regulation. Very few people with CHARGE syndrome will have 100% of its clinical features. As far as prevalence and epidemiology, research studies have shown that CHARGE syndrome can occur in 1 in 10,000 births. Most cases found to be in Canada at 1 in 8,500 live births, and no teratogen or exposure is known to increase the risk for CHARGE syndrome. Reoccurrence risk can range from 0.01%, 6%, or 50%. Comparing the general population to parents of children with CHARGE, the reoccurrence risk is unchanged, 0.1% or 1 in 10,000 live births. The presence of germline in one parent increases the reoccurrence risk to approximately 6%. A parent with CHARGE syndrome increases the risk to 50%. Reoccurrence risk increases to 66% if both parents have CHARGE syndrome. Prenatal testing is available. It can be conducted if CHARGE syndrome is present in one child. This is the acronym that Dr. Pagan described in 1981. C stands for coloboma of the eye, which is found in 80% of the patients. H stands for heart defects, found in 85% of the patients. A stands for atresia of the cornea, which is found in 57% of the patients. Retardation of growth and development is found in 70% of the patients. G stands for genital or urinary defects, and E stands for ear anomalies or deafness, which is found in 62% of the patients. Ear anomalies or deafness can occur either bilaterally or mixed hearing loss. Coloboma is a malformation of structures that form the eye. It can affect the iris, retina, and optic nerve. Research has shown that 75 to 85% of individuals affected by CHARGE syndrome have a congenital heart defect. Almost every type of CHD has been described, including ventral septal defect, atrial septal defect, and a patent ductal arteriosus. Many children have multiple complex congenital heart defects. Tetralogy Fallot is also seen in those patients. Atresia coniae is a developmental failure of the nasal cavity to communicate with the nasopharynx. It can occur either unilaterally or bilaterally. R stands for retardation of growth and/or development. Delayed language is often secondary to hearing impairment. Delayed reading and understanding often secondary to hearing impairment as well. Despite those impairments, several adults with CHARGE syndrome are known to be college graduates. G stands for genital urinary defects. Individuals frequently have hypogonadotropic hypogonadism, which affects the production of hormones to direct sexual development. Males are often born with unusually small penis and undescended testes. External genitalia abnormalities are less often seen in females with CHARGE syndrome. Children with CHARGE syndrome also present with some behavioral patterns. Autistic behaviors have been noted due to the delayed language and social interactions to others. OCD behavior patterns have also been described. Children with CHARGE are described as stubborn and single minded. ADHD disorder is also a common presentation in children with CHARGE syndrome. Social immaturity is also a major concern due to the challenge of making and maintaining friendship. E stands for ear anomalies. Most children with CHARGE syndrome have unusual external ears. The typical ear is short and wide with no earlobe. As you can see, the three children affected by CHARGE syndrome share similar physical characteristics. You can notice the ear malformation, the facial palsy, coloboma of the eye, and the third little kid, you can notice the swallowing problems that he's having. He's got a G tube in place. This is a picture of the CHD7 gene with the chromosome 8 malformation. As far as genetic testing evolves in specific genetic testing for the CHD7 gene, there's a lack of awareness on genetic testing for CHARGE syndrome. It's either a lack of available resources, no known benefit, or a lack of insurance coverage. Testing is available at Emory University and the University of Chicago. $2,400 is the cost for the procedure. Some insurance companies sometimes they do not pay for the genetic testing, although this is changing rapidly as genetic testing is becoming standard across all aspects of medicine. For some physicians, the current standard of care is to diagnose cases based on the clinical features alone. There are two diagnostic criteria for CHARGE syndrome. On the left side of the page, you can see Blake's diagnostic criteria. Basically, it's a definite charge if four major or three major and three minor criteria are met. It's a probable or possible charge if one or two major and several minor criteria are met. On the right side of the page, you can see Verlo's diagnostic criteria. The diagnostic criteria interpretations for Verlo is a typical charge if three major or two major and two minor criteria are met. Partial or incomplete charge if two major and one minor criteria is met. An atypical charge if two major or one major and three minor criteria are met. So based on the ICD-10, CHARGE syndrome is listed as a Q89.8, which is a specific ICD-10 code that can be used to specify a diagnosis. CHD7 mutation analysis diagnostic in more than 90% of individuals refer with presumptive CHARGE syndrome. If the CHD7 sequence is normal, this should be followed by analysis and then high-density microarray. High-resolution karyotype, which is a chromosome analysis, may be considered if the microarray result was normal. BUN creatinine electrolytes is also ordered to evaluate and monitor for renal function. LHRH and HCG levels can be used to evaluate and monitor genital hormonal development. Growth hormone levels can also be used to rule out or rule in growth hormone deficiency contributing to growth retardation. CBC count immunology studies can also be used to evaluate immune defenses. Immune deficiency has been reported as primarily a T cell based humoral, even appearing like Omen syndrome. Early involvement of cardiologists, ophthalmologists, endocrinologists, and ENT surgery is important. Treatment also involves correction surgeries needed. Such surgeries can include choanoatresia and heart defect. These patients they can also suffer from swallowing problems, GERD, chronic recurrent otitis, sinusitis, detached retinas, short stature, scoliosis, ADHD, OCD, high pain threshold, and social immaturity. Follow ups to monitor growth and development is important. The need to continue assisting and supporting patient and family reaching development milestones is part of the plan. Parents of children with charge syndrome should be encouraged to be in charge and active advocate for the children in order to ensure development of an educational program that will allow each child to reach his or her full potential. Children with charge syndrome will vary greatly in their abilities in the classroom. Some may need little support, while some require full-time support in individualized programs. Parents should make sure that before their child reaches age 18, they have established which doctors and specialists will follow the individual with charge syndrome in adulthood. Even if the young adult is in charge independent, it is important to help them maintain their independence by helping them move from pediatric doctors to new doctors who will follow them as adults. The Ethan Wolf Recreational Assistance Program was created to make sure all individuals with charge have a chance to play. Through their involvement with Charge Syndrome Foundation, they provide direct assistance to individuals with charge and their families. Babies born with charge syndrome have a life-threatening birth defects. Despite their hearing loss, vision loss, balance problems, and a host of other serious medical issues, many of these children overcome challenges to far surpass expectations. Thanks to the Charge Foundation syndrome, individuals with Charge syndrome and their families have a place to turn for information, research, support, and hope. Some additional resources include the Texas School for the Blind and Visually Impaired, psychological evaluation of children who are deaf-blind. The DBIT Link was a national information clearinghouse on children who are deaf and blind, and Carrot Notebook is basically to help organize medical records and/or appointments. These are some differential diagnoses that I found. Some chromosomal abnormalities that have similar characteristics when compared to Charge syndrome. Retinoic embryopathy occurs when there has been exposure to Accutane during pregnancy, and you can produce similar ears and heart defects. Other features differ. The PAX2 mutation can also cause colobomas and hearing loss. The Kabuki syndrome can have many of the same medical and behavioral features. The eyes and the fingertips they are different, and puberty is early in Kabuki syndrome. The VATER association can result in similar medical problems. The ears, face, and hand do not look like Charge syndrome. In conclusion, CHARGE syndrome is an autosomal genetic condition affected by CHD7 mutation. Genetic testing is available, however, most diagnoses are typically performed on physical assessment alone. CHARGE syndrome is a complex condition that requires collaborative care, continued monitoring, and support over the lifespan of the individual. These are some of the references that are used to complete this project. This is page 1, and this is going to be page 2.